I'm so excited to be here today to be able to talk to you all about COVID-19. These are my disclosures. And so the things that I really want you all to take away from this talk are three big things. I want to go over the current epidemiology of SARS-CoV-2. I also am going to describe the current vaccine recommendations, but more importantly, I'm going to go over the bivalent booster efficacy data in order for all of you to better be able to advise your patients about it. And then finally, we'll close out with the current treatment options for SARS-CoV-2, and I'm going to go over their mechanisms of action as well, just so that you can sort of explain to your patients in an informed way, like how these medications end up working. So as we all know, it's been a very long 3 years. In February of 2023, President Biden announced an anticipated end to the national emergency that was declared back in March 2020. This national emergency is scheduled to end on May 11th, 2023. And by no means does this mean that COVID is gone. It just means that we're no longer in this sort of state of crisis with relation to the disease. And part of that's because the incidence of cases has gone down dramatically. This is a result of multifactorial factors, including changes in seasons, viral evolution, as well as increased immunity within the whole population and our previous mitigation efforts as well. Taken together, we can see that you don't need to be maximized at any of these points to decrease rates of infection. Just even having most people having prior immunization can help decrease the frequency of transmission among patients and people. Talking about going from an epidemic to an endemic disease, I want to go over sort of how the rates have changed. So when we talk about a disease being epidemic, what we're really saying is that there are these huge variations in number of cases to the point where we can't really predict when we have these peaks in cases and when we have lulls. So for example, in winter months, which is highlighted, which is in blue here, you may have a huge outbreak, and then in the next season in summer, you may have another outbreak, and then you may go most of the following winter without many cases, and then towards the end into spring, you may see an increase in cases. Whereas when we talk about diseases that are endemic, there's a much more cyclical and notable pattern to the disease itself. So when we think about flu, and what I anticipate will end up happening with COVID as well, is that there are increases in cases that we see in the winter months, followed by decreases in number of cases during the summer. And with this predictability, we're better able to sort of control transmission of disease and also anticipate when the best time to give vaccines is, and sort of increase our supply of treatment as well. Looking at how COVID has been going over the past 3 years, what I have here is the number of cases since January 2020. We all remember that very notable winter last year when we had a lot of cases of COVID, but since then we've never really reached as quite high of a peak. And instead, it seems like the number of cases has sort of begun to flatten out and been much more predictable and consistent. Similarly, the number of deaths caused by COVID has gone down dramatically since the beginning of the pandemic. And we sort of flattened out a little bit to be a much more manageable number. And with all of this changes in the incidence and the rate of infection, what we've seen now is a move towards sort of business as normal. And so MedStar, in fact, has decided to make masking optional as of April 10th, which I think if we look back at the number of cases that are showing up in the United States, I think it's a very reasonable thing to be doing. I want to point out, though, that for our patients who are immunocompromised, there is the option to place an order in the computer when you put in your admit note. You're putting your admit orders, which I think is important for all of the residents and people who admit patients to place an order to say masking is required. And this is really recommended for patients who are considered higher risk. And in the example, they gave immunocompromised patients. And then it's also allowed for patients who request it. So my piece of advice to all of you is that if you are going to admit somebody, rather than sort sort of waiting for them to say whether or not they want they want their healthcare providers to be masked. I would say consider that asking that in the during your HPI or during your review of systems, making sure that you know what your patient's preferences are, so that we can accommodate what our patients want. That being said, I know it's also saying that, putting in this order for patients who are immunocompromised is basically saying, well, doesn't that mean like all of our patients in this hospital should be put on having this mask order placed? I think the other thing to keep in mind is that immunosuppression and immunocompromise, even though we use it as this global term, it really encompasses a lot of different types of patients who themselves carry different risks for infection. I want to say that my advice would be that anybody who is a solid organ transplant, anybody who's on a lymphocyte depleting agent, so anybody on an anti-CD20, and then our stem cell patients and our patients with acute leukemias or hematologic malignancies, those are the patients who I really think it's important that we keep them on isolation. Patients on TNF alpha inhibitors, maybe low doses of steroids, I think it's less critical that we continue constant masking around them. And with that, I'd like to go into the viral structure and the disease pathogenesis, because I think a lot of this then informs our understanding of the treatment options and the vaccines available. So talking about COVID, this is a schematic. The two parts of the virus that I really want to highlight are the spike protein and the envelope protein. The envelope protein is important because of the fact that it plays a role in the severity of disease. This is something that's being studied within basic science research. And the spike protein is important because this is where the receptor binding domain is located. This receptor binding domain is what's responsible for binding to the ACE2 receptors on our cell, which then allow the virus to enter our body. The spike protein is also important because the mRNA in our vaccines essentially instruct our body's cells to make this spike protein so that our immune system can recognize it and make antibodies directed against the spike protein. Just going into the spike protein in a little bit more detail, essentially what happens is that the receptor binding domain of the spike protein interacts with the ACE2 receptor on our cells. It's then cleaved by a protease and exposes this S2 prime site, which then becomes activated and allows it to fuse with the cell membrane and enter the cell. And now this is a very busy slide just showing the pathogenesis of disease within from SARS-CoV-2, but breaking it down step by step. Essentially, once the virus enters the cell, it then ends up replicating, and in the process of replicating, it makes the proteins that it needs in order to enter out, to like reform its virus and enter out into the cells. As part of that, there are like inflammatory cytokines and things like that that are released from the cell as it realizes that there's something wrong, there's something abnormal going on within the cell itself, including things like IL-6 and other chemokines. As a result of this, T cells, macrophages, monocytes, all of these things are activated, and then they come to help clear out the infection. And this picture right here at the bottom is just showing in a patient who has the ability to mount an immune response, somebody who's been vaccinated. Essentially, in the ideal setting, what would happen is that our innate immune system and our adaptive immune system would come together and would take care of the virus before it's able to cause any further damage. And this is really when the antiviral medications that we'll talk about later have their best effect, because all of this damage is being caused by the virus itself, as opposed to inflammation secondary to the virus, which is what we typically see in patients who've had no exposure to COVID in the past. And this dysfunctional immune response is really what we saw at the beginning of the pandemic, and we're not seeing quite as much of now, just because of the fact that most people have been vaccinated against COVID or have had prior exposure. And so what ends up happening in this sort of situation is that, yes, there still is some viral replication, but the main disease mechanism is a result of increased release of cytokines, increased infiltration of monocytes, T cells, and macrophages. And this can all eventually culminate into pulmonary edema, pneumonia, and then just widespread inflammation elsewhere. And so this is when we have benefit for giving immunomodulatory medications. So this is more for like our ICU patients, the people who are requiring oxygen. What we want to do is give medications to sort of dampen the immune system. With that, I'm going to go into the current variants that are in circulation. This is just a family tree showing sort of how COVID has evolved over the past couple of years. You can see that really since June 2020, so for almost a year now, 9 months, all that's been in circulation has been the Omicron and its subvariants. And when we take a more granular look at the Omicron variant,
is that the one which you downloaded or just
what we end up seeing is that XBB 1.5 is the virus that, or the subvariant that is currently predominantly in circulation, but we also have BA4, BA5. I have that highlighted because of the fact that the bivalent booster vaccine is sort of targeted towards this specific subvariant. They both share the same spike protein, and so these two different subvariants are distantly related to each other via the BA2 subvariant. I'm also going to highlight that I anticipate that XBB 1.9.1 and XBB 1.5.1 are going to be the newer variants that end up coming into higher degrees of circulation within the population in the coming months. And so I also want to highlight, though, that when we talk about like these different subvariants, it's not just based on the spike protein. There are also differences within the envelope proteins, within other components of the RNA genome, which make them their own subvariants. And this is just a graphic from the CDC, just showing the shift in subvariants in circulation. So right now, as I had mentioned earlier, XBB 1.5 is the most common subvariant. And then we have the XBB 1.9 and 1.5.1 also growing in prevalence. XBB compared to other Omicron lineages, I think that it's important to keep in mind that it is twice as infective when we look at it in the lab compared to sort of the ancestral strain of COVID. And additionally, unlike the other Omicron subvariants, the infectivity in lung epithelial cell lining is more similar to the ancestral viruses, because things like BA2, some of the other variants that I had gone over before, were not quite as infective or able to bind to and enter lung epithelial cells as well as XBB has been able to. And it's also thought that the severity of illness is decreased due to mutations within the envelope protein, which is what's thought to sort of stimulate a lot of the cytokine release within cells. Along the lines of similar differences from Omicron compared to prior lineages, I want to also point out that there are higher CT values or cycle threshold values associated with replicating virus. What this means is that even though it requires an extra couple levels of replication in order to detect that virus is still viable and able to infect people. This is more relevant when we talk about lung transplantation and whether or not we can use COVID positive organs, because generally speaking, within this patient population, the CT values have been a very good guide as to whether or not we can take those organs for transplant. But with this increase in CT values having replicable virus, I think that we're going to see sort of a shift to being more conservative in terms of what can and cannot be accepted within the lung transplant world. In summary, with regards to the variants, spike protein mutations determine the virus's ability to bind to cells. Vaccine-induced immunity targets the spike protein. The envelope protein is associated with severity of disease. And then current lineages and some lineages have better binding, but are thought to be less virulent compared to the prior variants and subvariants we've had. And with that, I'm going to go into the vaccines. I've shown this slide at my previous grand rounds. This is just showing the vaccine recommendations for patients who are both immunocompromised and non-immunocompromised. I anticipate in the coming months that they will end up recommending another dose of bivalent booster for our transplant recipients, for our immunocompromised patients, and for older adults. But I think it's just a matter of when the group is going to meet before that decision is made and made official. Just as a quick reminder, we're seeing even more evidence that our solid organ transplant recipients, essentially all our immunocompromised patients, really do benefit from additional doses of vaccine because both their antibody response and their cellular response increases with each additional dose. And this is from a meta-analysis. But when we talk about the current bivalent vaccines that are now available, this is a study that was published in New England Journal of Medicine. It's busy and I'm going to break it down for you. So on the left-hand side, you see that we have patients who've never been infected with COVID-19. And on the right-hand side, we have patients who have had COVID-19. The green boxes indicate patients who were randomized to receive bivalent booster, and the blue boxes indicate patients who were randomized to receive a fourth dose of monovalent booster. And just as a reminder, the bivalent booster encodes or provides protection against both the ancestral strain of the SARS-CoV-2 virus. So it has like a component like the original monovalent vaccine has. And it also provides protection against BA4, BA5, specifically against that virus. And so essentially what they did was they measured the antibody response with regards to after they receive either the bivalent booster versus the monovalent booster. And what they found was that when they looked at the original strain of virus, that there was a 2.3 increased benefit to receiving the bivalent booster compared to the monovalent booster, and that there was an 8.8 times improved antibody response with the bivalent booster compared to the monovalent booster. However, when we go to look at the XBB.1, so that's like the ancestral strain for what the current variants are, that benefit, although it is 3.6 times that of the monovalent booster, overall, the total amount of antibody that's being produced is really not quite as robust as it is for the BA4 or the BA5 virus. And interestingly, in our patients who have had COVID-19 in the past, that degree of increase in immune response really is not quite as robust in difference between the bivalent versus the monovalent vaccines. And this is another New England Journal of Medicine study, just sort of showing the same sort of concept that essentially with the monovalent boosters, yes, you do get a boost in antibody response, and a similar thing happens with the bivalent, but our responses to XBB, to some of the other things that it is not necessarily targeted towards, is not nearly as high as it is to the original ancestral strain. And then that brings me into sort of, well, that's what happens immediately after vaccine. How is our immune response 3 months out from receiving the vaccine? So this is a study from a preprint that was done out of Beth Israel, a study that was done out of Beth Israel in Boston, looking at essentially baseline antibody titers at 3 weeks after bivalent booster, and then 3 months after receiving bivalent booster. And what we see is that, yes, again, the response to the ancestral strain of SARS-CoV-2 is very robust, and it stays in place for those 3 months. But for BA5, remember, that's what the bivalent booster contains a component of. It does increase by about 20-fold, but this increase drops pretty significantly. It halves by 3 months. And this is why I anticipate and think that they're going to end up recommending another dose of bivalent booster for our immunocompromised patients, because we know already that they don't initially mount quite as robust a response at baseline compared to non-immunocompromised patients. But in addition to this, because we see such a drop in antibody titers, I just anticipate that that same effect would be seen at a higher rate in our suppressed patients. And then this graphic just shows that CD4 and CD8 T cell responses are really not quite as robust 3 months after receiving the vaccine. And part of why there's this thought that and just to sort of go back a little bit, you know, you don't get quite as high of a response to the BA.5 as you do with the ancestral strain, even though there still is, you're still sort of targeting that specific viral subvariant. And part of the thought as to why this happened is this concept of immune imprinting. So this idea is that the initial exposure to one virus strain effectively primes all of your B cell memory cells and basically limits development of other B cells and neutralizing antibodies against even minor variants against that strain. And this concept is well known within the flu literature. They call this the concept of original sin, where essentially you've seen one form of the flu virus, and after that, all of the antibodies you make are really mostly targeted towards that original flu variant. Putting this in picture format, so essentially you get your first dose of vaccine and you get this big spike in your antibody production. And say that they now modify the vaccine a little bit, they keep a major component of the immunogenic, of the thing that's causing the immune response, but they alter just a tiny component of it. What you're going to end up seeing is that our bodies are kind of lazy, right? It's like, I already know how to make most of this, so I'm just going to put my effort into making the thing I already have seen before and I know how to do. And then I'm going to kind of half-heartedly make antibodies against this new thing, this new component of what I'm being exposed to, but it's not going to be as much as the thing that I already know. And we sort of see this effect just perpetuate itself with successive minor changes to vaccine. But all of that being said, that's all stuff that's done in the lab. When we look at it from a population perspective, what I really want to hammer home to all of you is that some vaccine is better than no vaccine, and that the difference between being up to date on your vaccine and getting that bivalent booster versus having only received the initial strain really comes down to COVID-19 associated deaths. So in this black line over here, what you see is patients who were never vaccinated against COVID. These white dots are just patients who only received the original monovalent series, and these blue dots are patients who have received the bivalent booster. And so you can see here that patients who aren't vaccinated are much more likely to get COVID, and that patients who receive the bivalent booster really, the rates are pretty similar, but there's a slightly less chance of you getting COVID with having a bivalent booster. The effect of the bivalent booster, though, is a lot more apparent when we look at actual deaths caused by COVID-19. Patients who have the bivalent booster are a little bit less likely to die compared to patients who have only received the monovalent booster. But both groups of patients are much better off compared to patients who've never been vaccinated against COVID-19. So, in summary, for when we talk about vaccines, I still recommend the vaccines as scheduled. I really do think and hope that we will get sort of permission from CDC, FDA that our immunocompromised patients can receive another dose of the bivalent booster. I think it's also important that our patients understand that it's not completely foolproof, that they can still get COVID, but that their risk of dying is much lower than if they weren't to be vaccinated at all. And then I think because it's not completely foolproof, just make sure that your patients have testing kits available at home so that if they do have any symptoms that they can be tested and then they can receive treatment immediately. And with that, we'll go on to treatment. So this is just, again, another schematic just showing that, the antivirals that we use are really, their efficacy and their effect are much greater at the beginning of illness when most of the disease process is being driven by the virus itself, as opposed to later on in the course of illness when you have just overwhelming inflammation, cytokine release, et cetera. And so to bring up this graphic again about the COVID-19 risk continuum, because I think it's I'm sure all of you get calls from your clinic about patients who are just telling you that they have COVID, and it's sort of hard to tell who is it that I should be treating, who doesn't necessarily need treating. So as with anything, there's there are differences in risks, right? So we've already gone over immunosuppression, but that's not the only sort of risk factor that we need to consider when we're deciding who should be treated and who's okay not going forward with treatment. I want to highlight that age is one of the most important risk factors. So my advice to all of you is that if you do have patients who are 70 and older, that I would strongly encourage you to consider treatment for these patients, because they're much more likely to have mortality and morbidity from COVID-19. Additionally, patients who have a lot of medical comorbidities, patients who are unvaccinated, these are all the patients who I think I would try to be a little bit more persuasive towards in terms of like recommending some sort of treatment for them. In terms of treatment, we've kind of had a sort of narrowing down of what is available for us to give to our patients. If they call us within 5 days of symptom onset, nirmatrelvir and ritonavir, as well as molnupiravir, are both available options for these patients. They're both oral. And then if they call us within 7 days of symptom onset, they may also be able to receive remdesivir instead. I want to point out that with all three of these drugs that are available, even with the current variants, they still retain their activity. There really hasn't been any evidence of any sort of viral resistance to any of these three drugs from the current variants that are in circulation. Going over remdesivir, I think this is my preferred drug to prescribe, mostly because I take care of a lot of transplant patients, and as a result of being on tacrolimus, they can't receive nirmatrelvir or ritonavir because the ritonavir interacts with the tacrolimus. So essentially what ends up happening with remdesivir is that it essentially completely inhibits RNA replication by sort of inserting itself within the RNA sequence and then terminating any further addition of chains to the RNA. And we have data now that shows that patients who have mild illness that doesn't require hospitalizations, rather than doing the 5 days that we typically do for our hospitalized patients, you can do 3 days, and we see a benefit compared to placebo in terms of cumulative hospital or death from COVID. And this data has actually been replicated within our transplant patient population, where 3 days of IV remdesivir compared to no treatment had lower rates of hospitalizations when compared to placebo. And I think that this sort of data can be transferred to some of our other immunocompromised patients, where I do think 3 days of remdesivir for somebody who is on steroids or who has been on a CD20, an anti-CD20 agent, I do think that this is a good option for them. And then Paxlovid, on the other hand, acts at the protease, and it essentially inhibits the protease from working. We see that in non-pharmacy funded studies that nirmatrelvir, ritonavir reduces the time to a negative PCR when it's given earlier on in the course. So that's part of why it's recommended that we give it within 5 days of symptom onset, as opposed to after 5 days of symptom onset. And I know that this is just an important nuance to keep in mind, because a lot of times people will have symptoms start and won't test positive until 2 days later. Remember that when you're counting the days from symptom onset, it's not from that positive test, it's truly from when their symptoms started. And just as a reminder, myself, Dr. Kumar, and Dr. Ayub are doing a study looking at whether or not nirmatrelvir or ritonavir should be given for longer durations in our immunocompromised patients. So if you do have a patient who tests positive for COVID and isn't on any drugs that would maybe interact with ritonavir, please call us, because we would be very happy to talk to them about the study and offer them, to be enrolled in the study. And then finally, I want to talk about molnupiravir, which is sort of our default drug when we can't give remdesivir and we can't give Paxlovid. This is my least favorite of the 3 drugs that are available. The way it works essentially is that it inserts mutations into the RNA as it's replicating. And so the idea is that with enough mutations, the virus isn't able to propagate any further. But this this really doesn't have much difference when we look at outcomes compared to just symptomatic management alone. I think the only population where there may be sort of a signal towards maybe there's an improvement with molnupiravir compared to placebo or compared to just, symptom management is in our immunosuppressed patients where we see that there's a little bit of a benefit with it. And I think, though, that I wouldn't say that molnupiravir is completely off the table because people who do get it generally tend to say that they feel symptomatically improved earlier than people who don't receive molnupiravir. But it's just not going to necessarily prevent hospitalizations or death. And with that, I think the big takeaways from this are that when you assess for treatment needs, make sure that you're considering the whole patient, not just whether or not they're immunocompromised or not, just consider their age, their vaccine status, et cetera. Remdesivir and nirmatrelvir, ritonavir are the first line options. And then finally, there haven't been any documented variants with resistance to the available treatments to date. And so in summary, or like my closing thoughts about all of this is that even though the public health emergency and the national emergency are ending, it doesn't mean that COVID-19 is not important and that it's not going to continue to be in our lives, but rather I think that we're not in that crisis mode that we were back in 2020. And that I do really recommend that our patients continue to receive the vaccines. I do think that the utility in updating the variants to include updating the vaccine to include variants along with the ancestral strain, I think that is to be determined how effective or how beneficial that is. But I think for the time being, I would just follow the CDC guidelines in terms of recommending that these patients continue to get the bivalent booster. And that is all. Thank you.